Fab. Thank you, Junaid. So, hi everyone. Thank you for joining this afternoon on a Monday. My name is Shanara Abdin. I work in Birmingham Public Health as their service lead in behavioural science, and my background is health psychology. So, I'm a registered health psychologist as well. I think we're overwhelmed by the number of people that joined us today, so we really do appreciate everyone who's taken the time out. The session today is very much around how we in Birmingham have applied behavioural science to MMR vaccine uptake. So the session is in different parts. So we'll start off with the current situation of measles within the city, and then we'll talk about behaviour change and vaccine uptake and how that links in with our decision making. And then the latter part of the session will be how we've actually applied behavioural science to the work that we've done here. There will be an opportunity for questions towards the end, but please do feel free to use the chat and we can go on from there. So firstly, I want to say thank you to our health protection team for the following slides. This just provides a bit of context of why we're here, really, I guess, in terms of the current situation of measles within the city. So measles is circulating in Birmingham and across West Midlands. As of last week, we've had about 480 cases since October last year, and a third to half of the cases have required hospitalisation. Most of the cases are within children under 10 years old. So what that means for us is if anyone is local to the city, you may recall that we did have a measles outbreak back in 2018. The box that you can see kind of provides a comparison, really. So back in 2018, we had about 116 patients or so, which started in Birmingham. However, now currently where measles is circulating, and as I said, a third to half of the cases have required hospitalisation, and majority of those cases are within under 10 years. So these are a few messages that our health protection team use quite a lot with when we're talking about MMR and the measles outlook here. So MMR provides the best protection against measles. The vaccine itself, there's two types. So one contains pork and one doesn't. So the non-pork version is called Priorix, and that's available at GP surgeries. What we're asking people to do is to contact your GP surgery to catch up with MMR immunisation at any age, whether you're a child or an adult or anyone. If you're unsure, please do contact your GP surgery. What we're asking people to do is anyone with suspected measles should not attend a healthcare setting without calling ahead first. Measles is really contagious. It's a lot more contagious than COVID. So as you can appreciate, we are trying to do as much as we possibly can to improve the rates of MMR vaccine within Birmingham, but across nationally and regionally as well. So that's just a really quick context, really, in terms of why we're here today. Why are we talking about measles and the MMR vaccine? Now, the work that we'll be talking about today actually starts before the outbreak. So it started prior to October. When we did start some of the work, which I'll go through in a bit, we didn't actually know we were going to be in a measles outbreak. So before I talk to you about the work, I just wanted to talk about behaviour change and vaccine uptake and how that relates to any decision that we possibly make. So in the chat, I appreciate we've got quite a lot of numbers on. So if you can just use the chat, just answer this question for me, really. What does behaviour change mean to you? So if someone said to you, what is behaviour change? What does that mean? What instantly comes to your mind when you hear the word behaviour change? So please feel free to use the chat. Just want a bit of an idea, really, of the thoughts that we all have in terms of what does behaviour change mean to you. Is anybody going to be brave and kickstart writing it in the chat? Anybody? I know it's Monday afternoon. But what does behaviour change mean to you? Fab, thank you, Serena. So approaching things differently, doing things differently, thinking about things differently. We've got adjusting behaviour, got redirect opinion and behaviour using facts and information, changing what we do, education, altering habits and behaviours for the long term. Fab. Thinking about external factors that impact behaviour. Excellent. So the next question for you all is, why do we think changing behaviour can be difficult? So what is stopping us from, going for a vaccine jab, etc.? Why do you think changing behaviour can be difficult? So anybody want to start that one off? Resistance to change is built into any human. Yes. Perfect. A lot of behaviours are ingrained or automatic, cultural barriers, competing priorities, individual beliefs, societal pressures, fear of negative outcomes. I obviously can't read as I can't talk as fast as I can read. Influences, opportunity to do so, capability to make the change, requires sustained change. Fabulous. So I just wanted to ask these questions just to get your thinking going, really, is, as you've all rightly covered, if behaviour change was easy, we all would have done it. However, there are a number of factors that influence why we do something. And for the purpose of this webinar, we're going to be focusing a lot around vaccine hesitancy. However, we can use this anywhere and everywhere. So behaviour change aims to understand our thoughts and our processes. So it's all about what we think, what we do, and what we feel. And as I said, you can apply this anywhere, whether it's in health or illness or policy, anywhere. It's quite broad in terms of behaviour change. So you might be asking, what is behaviour change? If you type it in Google, you'll probably get a number of definitions. This is one that we use quite a lot in our behavioural science team because it's just simple. Behaviour change is doing something which causes you to behave differently. So all the answers in the chat, it just covers all that. It's, we've got different reasons why we do something. So whether it's culture, whether it's our personal beliefs, etc. So behaviour change, it helps us figure out why we do certain things. As I said, it's broad, so it can be applied to different situations, different contexts, etc. And it's valuable. So we should always think about it when we're trying to improve things. So this links into when I've said about policy and health, etc. It's making the decisions. It's all about how we can apply behaviour change to a context or topic. So now I'm just going to talk to you about vaccine hesitancy. Now, vaccine hesitancy, the official definition is the observed delay. So it's the observed delay in acceptance or refusal of a vaccine. And that's what vaccine hesitancy is defined as. So I appreciate the screen's quite small, but you've got 3 elements of this decision. So you've got complacency, confidence and convenience. So it's a 3 C's model. So influenced by several factors, including confidence, so that could be level of trust in the vaccine. And some of you may recall this came up quite a lot during the COVID pandemic, or the provider or the healthcare professional. Complacency, so the individual may not perceive a need to have the vaccine. So it could be the MMR vaccine, for example, is very child focused. So as an adult, if an adult hasn't had the vaccine, they could think, well, I don't need it. I'm not a child. I don't need the vaccine. However, that's incorrect, but that's just the way that they perceive their need or they don't perceive their need to get the vaccine. And they just don't value the vaccine. So that's complacency. And then we have convenience. So that is all around access. So it could be, physical access, going to your GP surgery, for example. It could be affordability, and health literacy and language barriers comes into convenience as well. So some of you, if you I've heard of the COMBI model before, may recognise this. So this is the model. It's a behaviour change model that's used quite a lot in public health practice, and it's one that we use in Birmingham. It's part of the behaviour change wheel, but the COMBI model, in essence, focuses on someone's capability, opportunity and motivation. So once you have all 3, in principle, it means that you can target that said behaviour. So for us, in terms of MMR vaccine, we must have the capability, which is split into psychological and physical, the opportunity and motivation. So with the capability, can this behaviour be accomplished? So can it be done? Does the individual have the knowledge to go and know why they need to get the MMR vaccine, for example? The opportunity. So is there sufficient opportunity for behaviour to occur? So this could be, does someone have support from their friends and family, for example, to get the vaccine? And then motivation. So is there sufficient motivation for the behaviour to occur? So for example, if someone had a bad experience before when they had a vaccine and they just think, do you know what, I'm never getting a vaccine again, had a sore arm, etc., that bad experience has put them off from getting vaccines again. So as I said, we must target one or more of these components to be able to change behaviour. And as I said at the start, we can apply this to anything that we do, any behaviour that we perform. So this upcoming slide, appreciate it's quite busy, but it does link into the MMR vaccine. It's similar to what I've just said, but it's demonstrated in a different way. So you've got your capability, opportunity, and motivation. But these are all questions that we just tend to ask individuals, whether that's, when we do one-to-one engagement, for example. So it could be, do the individuals know how and where to get immunised for MMR? Do they know what support's available, that they can ask questions, they can go to their GP surgery to double check if they have been vaccinated? Do they also know why they should get vaccinated? So that's really important. So it's all about knowledge, and do they know the importance and the benefits of getting vaccinated? Opportunity. So do they have the time to get immunised? So for example, if they're working 9 till 5, do they have the availability to go and get vaccinated during their work hours, for example? Do they have the encouragement, as I said earlier, to seek support, whether that's through friends or family or social norms? So us as humans, we are more inclined to follow the lead and follow the crowd. So it could be, do they have support from their friends, or are they kind of the odd one out if they get vaccinated, for example? So it's really just understanding why someone isn't getting vaccinated. And, the other question was, do they have the correct support system, processes and environments? So this is all around resources as well. So if someone lives in a rural area, their GP surgery is quite far, they have to take 2 buses, but those buses run every 2 hours. Will they make it in time to go to their appointment, for example? So it's all about making it easier for people to access services and, in this case, get vaccinated. And then motivation. So as I said, does their past experience on immunisation influence their behaviour? Or do they have the belief that getting immunised for MMR will lead to healthier outcomes? And also, do they have the belief that getting vaccinated and immunised outweighs any stigma attached? So these are all questions. These are just kind of sample questions that we could ask individuals and ourselves in terms of whether we do a behaviour. So in this case, whether we actually go and get the MMR vaccine. So I just wanted to provide a quick update, really, overview, actually, more than anything else, in terms of behaviour change and the background behind it before I started talking about what we actually have done and are doing in Birmingham. So how have we used behavioural science to increase our MMR vaccine uptake in Birmingham? So we've got 2 approaches. The overall goal has been to increase the uptake of MMR vaccine across the city. Now, as I said at the start, we have started, and we did start this work prior to the current outbreak. It was literally this time last year when we started doing primary research, which is currently just undergoing, which is an education intervention across the GP practices within the Washwood Heath area of the city. Now, this primary research, which I'll talk about shortly, has a focus on Romanian communities. And the reason that we have done that is the evidence that we've done literature reviews, we've also gone through the previous outbreak back in 2018, and it was very much focused around the Romanian communities. So what we wanted to do was create an education intervention to support GP practices, in particular professionals working within those surgeries, around behaviour change. And then we've got our current measles outbreak. So as part of that, what we've been doing is delivering a brief training on the principles of motivational interviewing across Birmingham, and I'll talk about that in a bit as well. As part of as part of both of those approaches, we have done community engagement. So the community engagement sits within every single thing that we have done. So what this means is we're trying to understand the barriers and facilitators of why someone either gets the vaccine, the MMR vaccine, or they don't. And that has really shaped the work that we have done here in the city. So the primary research that I'm going to start talking about is formal academic research. It's led by us within Birmingham Public Health. We've got our local collaborators, so the University Hospital Birmingham, we've got Birmingham Solihull NHS Integrated Care Board, so the ICB, and then, sorry, that is a typo, that is meant to say Birmingham City University, not Birmingham City Council. So we've got Birmingham City University supporting us with the evaluation. So a bit of background in terms of why we're doing this primary research. So evidence suggests that culturally informed interventions can address the barriers of the MMR vaccine. And in order to achieve behaviour change, it's really important to target professionals. And that's professionals who work in healthcare. So it's call handlers, it's receptionists, it's health visitors who are out in the community, and then it's your general practitioners as GP and nurses as well. So as part of our education intervention, which we've aimed at professionals working in those healthcare, we want to train them into motivational interviewing. And what evidence has shown is that that actually has the potential to increase professionals' confidence and change their attitudes, to have that discussion, to raise the conversation really on getting the MMR vaccine. So you may be wondering, what is motivational interviewing? I appreciate, with the purposes of the time, I won't go too much into this information, but there's links at the end of the slide that you can have a look. But motivational interviewing, in essence, is a collaborative and person-centered approach. And the entire idea of motivational interviewing is to strengthen someone's motivation for change. It's a conversation about change. It's collaborative, so it's very patient-focused, and it supports decision-making. And this strengthens a person's motivation to change their behaviour. So it's based on the individual's arguments. So we, as professionals, as practitioners, we cannot provide them with that information. They have to make that judgment on themselves in terms of why they are not performing or doing a behaviour. So what I mean by that is, in order to do motivational interviewing, there's basic techniques and skills. So the acronym that's used, and some of you may have heard this before, is OARS, which focuses on open questioning. So instead of asking questions, that are very yes or no, this provides the opportunity for the individual to tell us the story. So tell me about why you're not getting vaccinated, or tell me about why you're a bit hesitant about getting the MMR vaccine. So it's using affirmations, so acknowledgement and supporting the individual struggles. So going back to past experience, it could be someone's really struggled, had a really bad side effect from a jab, and you just being, acknowledging that they've had struggles. Reflecting listening, so reflective listening. So this helps to clarify and manage conflict. So this is basically demonstrating empathy. So it sounds like you feel a bit scared in having the MMR vaccine. Can you tell me a bit more about it? So it's having that open discussion with someone that they feel that they can trust you. And then the final bit is summarising. So that you're just basically summarising what they've said. So let me just see if I understand so far. This is what you've said, X, Y, Z. So this reinforces what's been said, and it shows you have been listening carefully. So these are all skills which can be applied within behaviour change. And what you can see on your screen is a model called Stages of Change, which is a behaviour change model. But what we've done is applied that in order to understand where someone is in terms of their vaccine decision making. So for example, someone could be pre-contemplating whether they should get the vaccine or not. And this individual is very much like, you know what, I'm not getting the vaccine. I don't want to get vaccinated, so I'm not doing it. And then you've got someone who's contemplating and they're just a bit umming and ahhing. So they're not sure about getting vaccinated. They're just exploring, but they're not there yet. So they're just a bit in the middle. And then you have someone who's preparing. So this individual is, right, I want to get the vaccine. I want to protect my loved ones. There's a measles outbreak happening in Birmingham and across, the country. I'm planning on getting vaccinated. Then that person moves on to action. And what action means is they've set a date. I'm going on the 1st of May to my vaccine appointment, and that's that action. And then maintenance. So that is maintaining their behaviour. So I will get vaccinated in the future. Or in this case, for the MMR, that means that they will go for their second dose if they haven't had their second dose already. Now, because we're humans, we can move up and down. So it could be someone's had both of their jabs for the MMR, but the idea is for them to carry on with being vaccinated next year when the flu comes. They just don't want it, so they could be back at pre-contemplation. So it just varies case by case, and it all depends on the individual's behaviour, their motivation, their capability and opportunity in order to get vaccinated. So going back to the research, what is our aim? So as I said, this is the formal academic research. So what we've done is to implement an education intervention aimed at professionals working in GP practices within the Washwood Heath area of the city with the Romanian community. So our research has been very data driven. It's been underpinned by evidence, and the evidence has said majority of the city's Romanian community live within the Washwood Heath ward. So that's why we've targeted that ward. The next slide is focuses on behaviour change and the COMBI model and intervention design. So I won't go too much into it, but on the left-hand side are all components that we need in order to design an intervention. And then on the right-hand side, it's what we've done for this intervention. So what we do is we have to decide on target audience. So in this case, it's professionals working in healthcare in Washwood Heath. We need to conduct a behavioural diagnosis. So we've done that using capability, opportunity and motivation. And then there's a range of interventions that we chose. So as is education, because we're trying to train professionals to deliver motivational interviewing. And then our implementation options are guidelines, which is very much hopefully what the idea is, that individuals can use this training and apply it to any other health behaviour. The intervention itself will be motivational interviewing, which I've discussed. And then the idea is for 4 weeks. So what we've actually done, it does say 4 weeks there, but we've actually split it into 2 weeks where we've done half a day sessions over 2 weeks in order to deliver the training. So ethical consideration. So as I said, it's primary research. So we've got ethical approval. So that's from the local university, and research governance from our Birmingham City Council. As a study will only focus on NHS staff, we've got IRAS, so Integrated Research Application System. And then the study adheres to the BPS, so the British Psychological Code of Ethics and Conduct, and the NIHR, so the National Institute of Health and Care Research, Good Clinical Practice as well. So in terms of rigour and ethical, we're pretty covered. In terms of who we've targeted, so I know I've said this a lot, but we've targeted a wide range of professionals working across GP practices within Washwood Heath. They need to have direct contact with patients and caregivers, and their job role offers a potential to engage in MMR vaccine promotion. So that could be receptionists, it could be nurses, health visitors, etc. So this is just a bit of a simple way to show what we're trying to do. So we've had the ethical approval. In terms of when someone is recruited, so to speak, to the intervention, they have to complete a pre-intervention questionnaire, and that focuses on their knowledge and attitudes of motivational interviewing. During the intervention itself, they are introduced to motivational interviewing. There's a bit of role play, so there's a bit of patient and professional role play using motivational interviewing. We talk about cultural competency and the barriers and facilitators to Roma and Romanian communities, which I'll talk about in a bit. And then we repeat the same questionnaire at the end to evaluate. And then, as I said, the idea is to improve knowledge and attitudes of motivational interviewing, and then in the long term, increase MMR vaccine uptake. So we've got 2 parts. Part 1 very much focuses on behavioural science and motivational interviewing, and why motivational interviewing is important within the MMR vaccine discussion. And then part 2 focuses on the challenges and solutions in terms of actually implementing MI, so motivational interviewing in practice. So before we did our intervention, as I said at the start, we've very much focused on community engagement. So as part of this community engagement, we did some focus groups with Roma and Romanian communities. And the reason that we've focused on both communities is because there has been a lot of confusion historically within the two communities. So for us, it was very important to understand the differences and the barriers and facilitators of these two communities. So this is just a bit of background of both of these communities for you. I won't dwell in too much into them. But what we did was we recruited via the Big Issue for Roma communities, and then DOOR for the Romanian communities. The methods that we used were focus groups, informal interviews, and secondary data via the DOOR organisation. So the reason that we went for secondary data was there were some individuals who just would not want to speak to us, but because they trusted DOOR, they trusted their organisation as service users, they were able to feed back on our questions, through our local contact. All participants received a £10 Love to Shop voucher, and all the engagement sessions were informed by existing literature. So this linked to behavioural science and Combi model, and also literature review that we did. The questions that we asked focused on topics such as understanding of measles and the MMR vaccine, why individuals in the community might not take their child to be vaccinated, and how professionals can support this process. So these are a few barriers in terms of what we found from the focus groups. So health literacy for Romanian community was very common. There was minimal knowledge of measles and its severity, and they didn't really recognise the word measles or MMR, and it wasn't translated very well within their language. There was also false information on social media, so a lot of COVID stuff. There was a lot of miscommunication and information, and that was easily transferred to the MMR vaccine. Distress of UK healthcare professionals. So what they were told was discouragement of childhood vaccination by Romanian doctors. And then community influence. So this was a major barrier for Romanian communities, partly because vaccination was stigmatised within their community, and mothers would often rely on God to protect their child from disease, which meant that they just wouldn't get vaccinated. And then similarly with Roma communities, we did have similar themes. However, the content was a little bit different. So Roma communities very much thought measles was chickenpox. They basically thought it was the same thing, and it was something that children just get, so they didn't understand the severity of the illness. They also mentioned that they prefer the word immunisation compared to vaccine. So this is something that we've actually used within our measles outbreak, and we're using the word immunisation. And that was partly because it sounds softer and a bit more positive. But when you say vaccine, they said it was a bit more forceful, whereas immunisation had softer connotations. Prior to COVID, they mentioned that they did have full engagement with the childhood immunisation programme, and then they just completely lost disengagement post-COVID. Some professionals also felt they were dismissed. Some residents, participants felt that they were dismissed by their healthcare professional, which meant it was a barrier for them to get vaccinated. And then religion came up quite a lot as well. So it was God's will as a reason why they wouldn't get vaccinated. So that was quite similar to the Romanian community, So in terms of facilitators, these are a few facilitators that both of the communities informed us with. So it was very much focusing around education of the MMR vaccine, and they felt that would really support their decision making. Some also suggested using shock tactics such as frightening messages or images, just to highlight the dangers of measles and what it actually can do if it's really severe. However, evidence outside of this, so if you look at external evidence, it does actually say not to use shock tactics, so it's a bit up in the air at the moment on that one. And then many expressed that if clinicians were to take the time to explore their concerns, they would be much more likely to trust their intentions and support the MMR vaccine. I've just seen a question which I'll just answer. So how many participants were there? So we had, sorry, I don't think I should have put it on the slide, my mistake. In terms of the community engagement, we had a total, I want to say about 20 odd. So I need to get the split, but if I can just double check with my team, just put that in the chat. So we had more Roma communities than Romanian, and then the Romanian communities, we had to get secondary data. But Isha, do you mind just getting those figures if you can? If not, I can make sure I circulate them with the slides. Just can't think off the top of my head, sorry. So in terms of the intervention, what we have done, going back to the research, is we have delivered this app within the Washwood Heath Primary Care Network. At the moment, we have, I think, about 10 or 11 professionals who have completed the intervention, and their job roles include practice nurses, care coordinators, pharmacists and nurses. So as I said, this is something that we're currently just in the midst of completing. The intervention will be evaluated, as I said, by the local university, Birmingham City University, and what they proposed is their intervention will very much focus on participants and stakeholders. So the stakeholders will be NHS colleagues that I mentioned earlier. It will also be about the training materials that we've used. It's very much understanding if people's confidence has changed in order to deliver motivational interviewing to their patients. So this is a bit more information that the Birmingham City University team have provided in terms of the pre-intervention and post. So it's very much around surveys, knowledge, self-efficacy, how confident someone feels to deliver and talk about motivational interviewing, and what that means in practice as well. So what I just wanted to talk about, show quickly, is some preliminary findings from our intervention. So what professionals have said is that it's very difficult to get hold of Romanian patients as they go back and forth between UK and Romania. So vaccines may not always be up to the UK schedule as other countries. So sometimes they may not align with the UK one. When we focused around empathy, which is quite important for motivational interviewing, professionals mentioned that they don't want to overload or come across as too forceful. And then within a very short 10-minute appointment, there's just not enough time to discuss issues like this. So they just felt, they weren't able to provide all motivational interviewing techniques. What they also mentioned was the second vaccine sometimes becomes a problem. So patients specifically will single out not wanting the second MMR, but will have all the other vaccines, and they will go for their first one, they just won't go for their second dose. And then, as I said earlier, barrier with translation. So if you don't speak the same language, you can't apply the techniques. And if not face-to-face, it might not translate properly, as some professionals are still conducting virtual appointments via telephone, etc. So if it's what they've suggested is because it's not face-to-face, they just feel like it may not translate properly. So at the moment, as I said, we're still completing this intervention, but the impact of the intervention, multidisciplinary team come together to address barriers and facilitators. This is very much a pilot, which is why the external evaluation will really support us in terms of how we can go and apply this across other GP practices or within other vaccine programs. The idea of the intervention is to equip professionals working with Romanian community and on how to actually have those discussions and start those discussions. And as I said, the evaluation will very much focus around changing attitudes. The potential to increase the potential to influence the current measles outbreak as well. So I'm going to now talk about the current measles outbreak. So what we've done for this is we have used the constructs of the primary research, so the constructs of motivational interviewing to deliver brief training across Birmingham. So how we've done this is a three-part approach, really. So we've started off by developing a training session. So we're using the principles of motivational interviewing, so it's very much telling people what motivational interviewing is, on raising the conversation around MMR vaccine. So we focused around vaccine hesitancy and behaviour change and how to have conversations using those principles whilst obtaining insights on barriers and facilitators, as I said, through our community work. And then the second part is training and upskilling volunteers. So as you can appreciate, we literally need an army of people to deliver this training session as part of this outbreak. So we have trained and upskilled volunteers, so they're public health professionals, to deliver sessions either online or face-to-face. And we've provided like loads of tips and support in order for them to do that. And then the third part is going out into the community and delivering this training session. So we have reached out to internal and external colleagues, so community, voluntary and third sector organisations, education, NHS, including health visitors and colleagues. So these are just a few barriers and facilitators on the brief training that we've provided. These are all things that Birmingham residents have told us currently within the current measles outbreak, in terms of what is stopping them from getting the MMR vaccine or what may help them. So links to autism, thought it is like chickenpox, so similar to the findings earlier. The safety of the vaccine, severity of the symptoms of measles, and families were reluctant to get the vaccine due to lack of information. So these are a few barriers. I couldn't put them all on the page. We've got a number of barriers, and what we're doing is applying and using those barriers to shape our delivery and our approach to support individuals. In terms of facilitators, so what they've said is to circulate resources in a range of languages. So what we're currently doing at the moment is sourcing out resources for the top 10 Birmingham most spoken languages across the city in order to cascade that information out. What we have also done is, for example, gone out to community groups and translated. So, for example, we've attended a Bangladeshi women's community group, and we have spoken about measles within their language, so in Bengali, to get that message out there. The other facilitators were using settings such as community centres and libraries, and that's something that we're currently exploring in order to get the word out. Using images to reflect the skin tone of different communities. So this has come up quite a lot, and we're working really closely with our colleagues across the health system, so the NHS ICB, and also UK Health Security Agency colleagues in terms of communications. And then using translator support with getting the message across. So with the community engagement that I mentioned earlier for the primary research, we did have translators for that. And then for this community work that we're doing, as I said, like even like Bengali community groups, for example. At this moment, so this is currently ongoing, as you can appreciate, we're still in the measles outbreak, but so far we have provided training to 288 attendees across 19 sessions, and they are face-to-face or virtual. We have also used resources and information from our primary intervention to provide more catered information sessions about motivational interviewing. So this has been especially important within NHS colleagues, so health visitors, core handlers, where we've actually delivered like a robust motivational interviewing training because they felt it was really helpful for their day-to-day work. As part of our outbreak response, some of you may have joined Fumi and I. So Fumi is our service lead in health protection, and myself, and we had a guest doctor join us last week on an MMR and Ramadan webinar. And that webinar was put on as a result of barriers that came up in terms of our community engagement. And because it's month of Ramadan now, there was a lot of, I don't want to get vaccinated during this month, but you can actually get vaccinated during Ramadan. So our webinar is very much focusing on telling people you can get vaccinated and giving them that knowledge. And then in terms of our measles outbreak response and the delivery, the brief training that I've mentioned, it will be evaluated by UK Health Security Agency, so UKHSA's Behavioural Science Unit, who will be evaluating this work for us. So I appreciate I have spoken to you a lot in the last 45 minutes or so. We do understand that there's a lot of information on there on those slides. As I said, the slides will be shared, but if I just ask Janae to just stop recording, feel free to ask any questions. We also have an evaluation for this session. If you could kindly complete that, that'd be really appreciative.